It's now my honor to introduce Dr. Rex Archer. Dr. Archer is the Director of Health for the City of Kansas City, Missouri. He's the Vice Chair of the Public Health Accreditation Board and chairs FAB's Accreditation Improvement Committee. Dr. Archer is past president of the National Association of County and City Health Officials. Please welcome to his own house, Dr. Rex Archer.
Thank you, Dan. So first order of business is I'm going to ask you to get out your pen or pencil because something needs to be corrected. Don't remember the particular Native American tribe in the Southwest that in their artwork they would always put one error someplace to let the evil spirit out. So if you pull up the PowerPoint presentation that has our staff picture here from when we won for the second time the Local Health Department of the Year Award, and we're the first department, in fact the only department that's won that more than once from our national organization. And that's those members that were attending that meeting that were able to get there for the quick photo op. But you'll notice that there's an error on this slide. I pulled this slide from another presentation that I'd used and updated the title, but I forgot to change the date up in the top corner. So you can cross that out and put the correct date there on April the 12th. I like this slide because it really does show a number of activities that sometimes we don't talk about enough. And you'll see Wonder Woman there with her lasso of truth, and I'll be talking a little bit about that as I move through this. I'm going to start off with a very quick 60-second exercise. And I'm going to ask you to write down on a piece of paper there every word you can think of that starts with the letter P that relates to what you do in public health or what you think public health is about. So get going. And as you do that, eventually I will ask you to circle the one that's the most important, and we're going to share that to the group here. Okay, time. Now look at that list and circle the word that you think is the most important. And then we're going to start in the back there, Tootie, and you can shout out the word that you circled, and then we'll just kind of move around with Captain and so forth, shouting out the word that you circled. Now, if somebody else has already shouted that word out, then you could say that word and then go to another word quickly on your list. If all your words have been used, then one of the words that everybody can put on their list is pass. Okay? So, Tootie? Policy, okay? Prevention. No, or people?
Yeah, I have prevention, but I put the promotion.
Promotion?
I put advocate.
Advocate, okay. We'll spell that with a P. Okay? Prevention?
I had prevention well, but I'll take protect.
Okay. Protect?
Partnership.
Partnership? Good. Okay. Promote?
I also have prevention and perinatal health.
Okay.
Passion.
Passion, yes.
Planning.
Planning?
Well, all of mine are taken except for one, so place.
Place, okay.
I have policy.
Policy?
Prenatal.
Prenatal?
Prevention.
Prevention?
Partner.
Partner?
Most of my Americans said, but I think also prioritize.
Prioritize, okay.
Population.
Population?
Most of mine is parades.
Parades, all right, celebrating, hey.
All of mine been taken, so I'll have it.
Okay,
Public interventions.
okay, public?
You say protection?
Yes, I think, but that's okay. Keep going.
All mine are taken.
Okay, Daryl?
Pass.
Okay.
Mine have been taken. Pass. Perseverance.
Perseverance, okay.
Mines have been taken.
Okay.
Prove.
Prove.
There's a inspection process for the environmental health people in the room. Probably aren't too many, but it's called HACCP. HACCP stands for Hazard Analysis Critical Control Board. A lot of inspectors would joke that it stands for Have a Cup of Coffee, Pray. So
Pray? Okay. So most of on my list, I had a few others, possibility, potential, etc. But the most important word that I had circled is actually up here on the slide. It's power. But notice that we went through the entire room, and I don't think I heard power from anybody. That is our problem. Now, some of you that heard me speak before know that I like to open up with a story of Mullah Nasruddin, who is a comical kind of wisdom teacher in the Sufi tradition. And Mullah was asked by students, a new student had come in and said, "How old are you?" And Mullah said, "I'm 40. And a student that had been with him a couple of years said, "Well, that's what you said 2 years ago." And the Mullah says, "Yes, I always stand by what I have said." Now, I share that because, I did want to, if you tweet, part of building power is reverberating our messages and sharing them. So there's my handle, and if you follow me, I'll follow you back, and we can take over the world. So the reason I share this is I guarantee that when I spoke 2 years ago at this MINK conference over on the Kansas side, there were some things there that I said that I've kind of evolved on and changed. For me, if I attend a talk and everything I hear is something that I already knew or might have guessed on a multiple choice test, then for me it's kind of a waste of time. If I don't hear something that I doubt or question, or it causes me to miss some sleep for the next night or two and I have to do some research to look at it, then it wasn't as useful for me. It didn't push me. So I'm hoping that I'll push you someplace in this talk and take you into some areas that you're not as familiar with. Grassrootspolicy.org, you'll see the link there, so that's in your handout, has an excellent document on the 4 faces of power. First face of power is the power of organizing. So when we organize around any specific issue to try to get policy passed, that's the first power. But what we're learning over time is that starting from scratch around a new issue and trying to build around that takes a lot of energy, and then you either succeed or don't, and everybody goes on to whatever they used to do before, that's not a useful way to build power and keep power. So the second one there is the power of political infrastructure building, relationships of people that have common values with you that you can then pull back together on the next issue. So as an example, we had never had renters and tenants' rights organized well in Kansas City really at all. But when we saw housing conditions and problems in the city that needed to be addressed, we didn't start that from scratch. We went to multiple other groups that probably had some crossover interest in this area, introduced them to the information and data, and then got them to organize. And that same collection of folks we tap on other issues all the time now. The third area, though, is where I'm going to focus most of this talk on, is the power of narrative, worldview, and ideology. Because if you influence, and I'll use the term control, if you control the narrative, you can protect the public health. If you don't control the narrative, you cannot protect the public health. And the last of the 4 powers is the power of being coercive, to maintain the status quo. And this is where we have power imbalances in this country, and the wealthy and certain special interest groups maintain the status quo or even make it worse because of their collective power. So I'm going to give you a couple lists, and these lists are of countries, and I'm going to ask you, what do you think these lists are about? And as you can see on this first list, Japan's number 1, Sweden 10, the US is 33rd, Russia's down at 110th. And actually, over the last 3 years, the US has dropped to 45th. And here's a list with the US as number 1, Russia number 4, Japan 7, Sweden 34th. Well, you would have guessed probably that first list is life expectancy at birth. How many of you in this room, I won't ask you to actually show your hands, but how many of you knew that life expectancy has gone down 3 years in a row in this country, and that's never happened in recorded history before? How many do you think of the public knows this? The other list was the medal count in the 2016 Olympics. Can you imagine if the US in medal count dropped to 45th in rankings, what an outcry there would be? All this money being thrown into it. Everybody in the public would know that we had slipped. How many of you have seen the YouTube video, Tale of Two Zip Codes? Okay, about half of you. So I'm not going to show it today. That's homework for those of you that haven't seen it. It's only 4.5 minutes. Whatever area you're from, this was developed by the California Endowment, so when you ever listen to it or you're showing it to an audience, just ask them to think of Nebraska or Iowa or Missouri or Kansas or your particular county or city jurisdiction. Every time they hear the word Californian, it can apply to your folks. As a spoiler alert, George Takei, Captain Zulu from Star Trek, is the narrator, and some people get lost trying to figure out who the narrator is and don't listen to it as well, so I'm kind of letting you know that ahead of time. Now, I believe that this room has a lot of the significant public health leaders from the 4-state region. And I love this definition that leaders are visionaries. How many of you are working right now on developing a more poorly developed sense of fear? To me, that's almost the top criteria for being a public health leader. If you can be afraid, in fact, in the Tanakh, the Old Testament, probably the most frequent verse is, be not afraid. Because if you're afraid, do you speak up to power? Do you take on the policy issues? Do you organize? Do you take the risks? Are you willing to believe that you can make the impossible happen? How many of you have heard of the probability 40-70 rule? So Colin Powell was the first one that I'm aware of that talked about this. And so just like we have probability in public health, the P40-70 rule basically says the P is for probability, and the 40 or 70 is the likelihood of success from a decision that you make. And you'll notice, and maybe the military can get away with this, if you make a decision before you're 40% sure, that's probably pretty risky. But if you wait until you're 70% sure, you may have missed the boat, or a lot of extra people have probably died. Now in public health, I hate to say, I think there are a lot of public health leaders that operate with the P95-105 rule. Now, I'm not saying that most of us can operate at a 40-70, but I try to operate in kind of a P55-85 range. And that depends on where's my political clout at the time, how powerful is the group that I might be taking on in that decision making, etc. But if you operate in that P55-85 range, you have to be very agile because you will make mistakes and have to correct, and you have to correct pretty rapidly. How many of you have seen the Public Health Scenarios 2030 work that has been put together by Kresge Foundation, Robert Wood Johnson? I'm seeing a few head nods. This, I think, is very valuable. You can Google this. As a health department and our health commission, we have adopted Scenario 3, which is not exactly the way scenario planning works, but we've actually taken it as this is the vision that we want to grow into. So as a health department, we are moving forward in this vision. And what you'll see is the woman there in the yellow dress is that chief health strategist, and we've added the word catalyst. We don't think it's enough to strategize. You also have to catalyze the transformation in your community. And we do that through affecting funders on making sure they're funding the best things. We partner with business. When we did Tobacco 21 here, we had 100 different organizations that the chamber already had signed up supporting Tobacco 21 before we even introduced it to the council. By the time it was heard the next week, we had 146. I didn't have to use any political clout in that case. Because on a probability of 40-70, that was pretty easy. I could have gone at the 40 level with that kind of clout and support. You'll notice up here in the upper right, supporting social movements. I'd argue that over the last 150 years, most of the progress in life expectancy has been done from social movements. If in 1920, what happened? Women got the right to vote. Would we have child labor laws? Would we have almost any of our public health protection laws if women weren't voting? I'm not sure we would. Then you've got the river parable, which most of you have probably heard multiple times, but you'll see folks falling into the water or preventing them from falling into the water, working with lots of different groups. But the illness care sector is a very minor part of our plan here in the city. Unfortunately, a lot of my dollars still go out to illness care, but we're trying to move more and more back upstream. And ultimately, we're working on environmental justice, social justice, and health equity. So from the river parable, how many of you have heard of the river parable in public health? Okay, most of you. Whether you've seen it quite this way or not, you'll see that the medical model, which we can't not know in this country, basically that unhealthy behaviors and risk factors lead to disease and injury, lead to death. But at most, this is 30% of the solution. If we move upstream, this is kind of like asking the 5 whys, or if you've got a 5-year-old that keeps asking why, and they say because, why, because, eventually you get past your knowledge or you get to the root cause. So as we move upstream, what we're seeing is that it's biased beliefs, our isms, that lead to harmful policies and practices that put our communities on life support. So we have emergency rooms to prevent death, we have clinics for disease and injury, we have health education, and we spend more than any other country in the world on this. In fact, what we spend on this side of the equation causes more disease and injury and causes our reduction in life expectancy. Because instead of putting it where it would make more sense and would save lives and prevent disease. And I'll show you that a little later. But if we're working with our communities, developing power and leadership, if we're promoting healthier policies and partnerships, and ultimately we're changing the narrative. We actually change how we think about things. A lot of people assume that we are consumers in this country and we consume health by getting it and purchasing it from a healthcare provider. And that's kind of the unconscious narrative. As we move towards inclusion and sustainability, we have inherent tribalism that's been with us culturally for a long time. But that dividing us against them is what leads to bad policies. Instead of thinking about health in all policies, we often hear fiscal notes on various policy decisions. Well, how often do we hear a health note? But I would argue that we should be doing health notes on almost all policy decisions. And ultimately, we have to create more resilient, transformed communities. Now be careful, in some communities, if you go in and talk about resilience, they'll get upset. And why will they get upset? Well, they'll say, why do we have to be more resilient? Why don't you change the things that are harming us that we have to be resilient against? So that's kind of an interesting aspect as you're working with communities. And ultimately, I believe that these upstream forces are where we should be using our power in public health and building our power. So as we move from cardiac surgery and exercise and smoking to clean indoor air bads, we start then dealing with poverty and patriarchy and the things that are actually causing our harm in our society. Now, the Robert Wood Johnson Foundation, the largest funding foundation for health in this country, talks about, see that bottom red box, or bottom red box there on the left? What's it say? A couple of P's, right? Policies and programs. Notice which word is first, though. Policies. We think a lot of times of programs in public health, not policies enough in public health. Those then influence health factors, and notice that the social economic factors are at least twice as important as clinical care. And I think as the research continues to grow, we will find that that's probably closer to 50% of the equation. Now, some of you may have seen this data before. This is life expectancy data here in Kansas City. The pink bars are the mortality rates in our lowest life expectancy zip codes. The blue are the mortality rates in our longest life expectancy zip codes. You'll notice on the slide, though, that I really don't call these as causes of death. If you think about it, almost everybody's dying because their heart stops or they stop breathing. So you could say that's the cause of death and put that on the death certificate, but what good would that really do us? I'll argue that these are symptoms. Cancer is not the cause of death, it's a symptom. Heart disease is not the cause of death, it's a symptom. I don't know how many times I might save somebody from a heart attack in the emergency room, and next year they died of a stroke, or 2 years later from lung cancer. Why? Because we didn't change the root causes. We were just treating symptoms. Now you'll notice there in the, close to the left there, homicides. Where everything else is about twice as high, homicides is like 20 times as high. And we're actually seeing the data now that the toxic stress of the adverse community events of homicide and violence are actually root causes for these other symptoms. And how's that work? It works through what we call toxic stress, or the technical term, if you want to impress your colleagues, is allostatic load. But toxic stress is what the public tends to understand better. Cortisol, norepinephrine are maintained at high levels, which then cause our hemoglobin A1Cs, our blood pressure, our cholesterols to be out of whack, which then cause those symptoms that are on the death certificate. So we've taken Galia's publication work for the US, looking at how many people are dying prematurely each year because they didn't graduate from high school, or because of our racial segregation challenges, or individual poverty, low social support, income inequality, or community level poverty. And then we've adjusted that and looked at that based on those risk factors. How many people in Kansas City would have died early because they didn't graduate from high school if everybody graduated from high school? Be zero, right? So what's happening here is just like with smoking or anything else, you're taking the relative risk factor of that condition times the population percentage in your population that have that risk factor to be able to figure out what the death toll is. And as you can see, somewhere between 1 out of 3 and 1 out of 2 of our deaths every year in Kansas City, Missouri are due to these 6 factors. And that's why I have 6 divisions in our health department, 1 for each of these. Well, no, I don't. I mean, that's the challenge, is that we aren't funded for where the real influence and bang for the buck is. So just to drive that home, if you look at a cohort of everybody in our city from 25 to 34 years of age, if they didn't graduate from high school, they're 17.5 times as likely to die in that same period as if they graduated from college. But notice, even if they graduate from high school and don't go on for additional technical training or college, they're still 12.5 times as likely to die in that 10-year period. We're not going to treat our way out of this. So Dr. Block, former president of the American Academy of Pediatrics, talks about that children's exposure to adverse childhood events is probably the greatest unaddressed public health threat of our time. And so if you look at this, on an average population, 1 out of 3 folks, probably in this room potentially, may not have any ACEs. And about half of us will have 1 to 3. But about 1 out of 6 of us may have 4 to 10. But if you're in certain zip codes in our city where we have more challenges, it's probably the reverse of that. We may have at least half of the folks in those zip codes having 4 to 10 ACEs. Now notice, if you look at the likelihood of becoming addicted to nicotine and being a smoker, it's 2.7 times as high if you have 4 to 10 ACEs than if you have none. And as you go down this list, you can see IV drug abuse, 16 times as high. Attempts to suicide, 19 times as high. So even if you're screening for suicide ideation, if you're not also screening for adverse childhood experiences, you're missing a huge amount of the risk factor for suicide and for suicide prevention. But if we're really going to prevent them, we have to deal with the adverse childhood experiences. And this is just one of the lists of 10 of those. The research is still evolving and developing on what adverse childhood experiences are. But you'll see the percentage of these different conditions that are influenced by or would go away if we didn't have ACEs. Now our chamber is fully aware of this. So we have our Chamber of Commerce saying, guess what, folks? We can't be competitive as employers if we're hiring folks that have lots of ACEs, because you can see absenteeism is twice as high if you have 4 more ACEs than if you have none or 1. Serious problems with performing on the job, 3 times as high. These are slides from our Chamber of Commerce showing that there's a 20-year difference in life expectancy if you have no ACEs versus you have 6 or more. Notice the economic toll. The pink is illness care costs, and employers do cover a fair amount of that. But notice it's productivity that's the real harm to our country and our competitive edge, plus some of those other costs there on the end. Now it turns out that all of the 4 states either have ACE data. What I've not found out is whether any of the states in Kansas, Iowa, and Nebraska have been redoing any of their ACE data since this original data set. Missouri is scheduled and doing their ACE collection in the BRFS this summer, so we will have data for Missouri now to help us with this. For you that are science fiction nuts, like me, I love this quote: "The human eye is a wonderful device. With a little effort, it can fail to see even the most glaring injustice." So this is that data I wanted to show you. U.S. social spending versus other countries. And you can see on percent of the GDP, we're actually in the top third of the countries. And when our GDP is higher than these other countries, on a per capita basis, we actually spend more on social spending than really any other country in the world. But notice there's the dark black line and then the lighter gray or blue line there. We're an outlier because our illness care system is taking up most of those dollars. So if you look at the social spending outside of illness care, we're in the bottom third countries. And that's why I'm saying that what we spend on illness care in this country causes more illness and injury and is why we've got the problem we've got. So as the World Health Organization says, why treat people without changing the things that are making them sick? So we treat them in the emergency room or hospital, and we throw them back out into the environment that caused their illness to begin with. State of Minnesota, this is a great report on advancing health equity that they gave to their legislature. Health is something we create as a society and as communities, not something the individual can purchase or produce alone. So again, that's part of that narrative. We have to counter the narrative that we're healthy because we purchase our health care from an illness care provider. Notice usually I don't say health care provider because very few of them do much prevention work. So why does government exist? Well, everybody in this room knows that we exist because there are problems that we have to work collectively on that you can't solve individually. You can't individually have a long lifespan by yourself. We have to do things collectively to create that. And ultimately, as a health department, we exist because collective action's needed. We have to change those conditions that are causing the problems in our society and in our city. So sometimes instead of being called the director of health here, I'm called the head coach. And if you think about a football team, they have a playbook. They have their offensive playbook, they have their defensive playbook, and then they have their special teams playbook. So as a health department, we have three parts to our playbook. Our first part, which is actually the most important for increasing life expectancy, is working on these social determinants of health. Unfortunately, that's where we spend the least amount of our resources because a lot of our resources are tied to specific things, and it's very difficult to work in this area with a lot of funding. We're working on it, but we don't have a lot of resources. Our bread and butter for 153 years has been communicable disease and environmental threats. But again, we're very tight on these funds because they haven't been increasing. And in fact, even though our budget has continued to increase since 2004, it's often growing in other areas, and we're really struggling. We've got sexually transmitted diseases, STIs going on right now. All three, chlamydia, gonorrhea, and syphilis are going up. And I tried to get 3 new positions to combat that, and we weren't successful this year in that attempt yet. Not successful yet. Still working on that. And actually, most of our money goes out to illness care of the city. We fund hospital at $26 million, but eventually we're going to be shifting these dollars to more upstream prevention so that we'll be getting these illness care providers to be doing a better job at preventing illness. We're targeting and looking at preventable hospitalizations. I don't know how many of you have seen this before where the two scientists are talking about developing guidelines and how the miracle occurs, and the one scientist says, I think you need to be a little more explicit. So if we think about information, in some ways you can think about essential services 1, 2, and 3, monitoring and diagnosing and educating. I put some letter scores up there. I think public health maybe in general is getting around a B- in this area. Our health department may be an A-. Guidelines. We're pretty good at policy implementation and enforcement. Again, public health is doing fairly well with this, and I think we're doing pretty well. But where the miracle occurs, this is domains 4 basically and parts of domain 5 of the essential services. I would say that public health at best is getting a D in its ability to mobilize the community and develop policies. And we've been working on this pretty hard since we did an assessment about 18 years ago here at this health department, where we felt we were really low on this, and we're still low, but we're moving up where I think we've at least got a passing grade, but we still have a long ways to go. So when we think about public health, it's a social justice enterprise where it takes truth, or that lasso from Wonder Woman, and power. And so we provide that public health research and data, the truth, but it's community organizing that brings the power. And we can't do it, either of us, by ourselves. But when we join together, we can create social movements. We can get rental ordinances passed so that we can protect our residents from landlords that are renting properties that aren't safe. I threw this in just because I'm so proud of our staff and what we've accomplished, and you can see a number of the unique awards and promising practices in that. We also learn a lot from a number of you and others across the country. I did want to mention, and we've got a panel later today, so we'll be talking more about accreditation. You can see that we only have 5 states that don't have accredited state and or local health departments. 80% now of the U.S. population is covered under either a state or local health department or both that's been accredited. This is the eye test. One of your handouts has this as a full page sheet so that you can have that to be looking at. I'm not going to go into this in a lot of detail other than to say if you're familiar with logic models, you've got the ultimate outcomes on the far right, and you've got the beginning inputs on the far left. Be walking through this a little bit more at another time, talk about this a little bit on the panel, but the basic issue is the white areas are things that all of us in public health need to be working on. The yellow is what the Public Health Accreditation Board is working on. The pink is what funders and researchers and our national partners are doing. And then the blue are the actual public health agencies and what they're working on. And I'm highlighting a few things here because the issue of branding is so important, because we don't have the power in public health that we need, because we're not investing in public health's role and recognition and increasing our visibility. If we had the marketing dollars that hospitals have, do you think we'd have the challenges that we have right now? So some of you have seen this slide before, whether it's creating your objectives and maintaining them, meeting the objectives. So this is just an EPI 2x2 where becoming accredited or meeting your objectives is the column on the left, not meeting them are the column on the right. The up and down rows, the top row is if you're perceived as very valuable by your community or if your perception is low in your community. Another way of saying that is, do you have political power or not? So in that upper left quadrant, let's take a police department as an example in many communities, or a fire department. They have high perceived value, and if they're succeeding and not a lot of people are dying from burns and fires or homicides, they get a little bit more money every year. However, if homicide rates go up or fires or problems start going up, what happens? If their perceived value is high, they get a whole bunch more money, the upper right quadrant. For many in public health, we're below the line. So if we meet our goals and objectives, we get asked to try to do it with a little bit less next year. And if we don't meet our objectives, we may lose our mission, or the head of the agency at least is removed. So the solution to this is not just coming over here and meeting our objectives. If we're not increasing the perceived value by the public, we actually can harm ourselves in the long term by meeting our objectives. So I had a nursing supervisor that I particularly liked, her often saying, the job is not done until, what, Tootie? The paperwork's done, right? If you just do it but don't document it, that's not enough, right? Well, you'll see I have an and there. And the public and elected officials know we did it, and they value it being done. So in public health, we pride ourselves at doing our work. But are we doing all 4 parts of the work? So out of sight, out of mind, out of budget. So one of the important things in FAB's standards are organizational brand strategy. And if you don't have that, if you're not working on that, you will not succeed long term as a health department. Now, another way of thinking about health is all these social determinants. And so at different times, our health department is engaged in any one of these. In fact, almost always, we're at least working on 2 or 3 of these at any one time. Why? Because they cause psychosocial stress and unhealthy behaviors, which cause inequities and injustices and disease distribution. I wanted you to think about never using the term health disparities except for to say why you don't use it. Because health disparities is too value neutral. It doesn't talk about the inequities and injustices that are causing those disparities. Ultimately, those social determinants of health are because of power and wealth imbalances in this country. And so again, if we in public health aren't engaged in all of these policy issues, then we're missing where the real benefit is. And ultimately, we have to look at our social structures, our institutional racism and class oppression, and our gender discriminations and exploitation. I love these definitions. I won't read them to you. I do like Margaret Whitehead's about differences. Health inequity is the differences in population, health status, and mortality rates. Why? Because they're systemic, patterned, unfair, unjust, and actionable, as opposed to random or caused by the individual. We often blame the individual for their health conditions instead of blaming all of us collectively for the conditions that we put the person into risk. John Rawls, in his theory of justice, talks about the way you can tell a just society is, would you have been willing to be born in any family in your jurisdiction? Would you be willing to take the risk of being born in those conditions? Going to that school district, living in that neighborhood, having a parent that's working 3 part-time jobs. Many of you have probably seen this slide. I remember the first time I saw this, it was all white boys on there. Then it evolved to this. There is a rendition where it actually shows the one on the far right way down in a hole. It's interesting, as I've been discussing this with different folks in neighborhoods, one person said, well, you don't even have to stand on the boxes if the fence was, see-through. And then somebody else says, no, you're still missing the whole point. Why aren't they in the stands? So as we have these conversations on race and equity and various issues. We have a lot still to learn, and I'm learning every day from our staff and from our partners in the community. Dr. Frieden, when he was New York City Health Commissioner and at CDC, he had this pyramid showing these factors that affect health. And yes, we have counseling and education, yet we're using condoms. But the fact is, if people don't do those things regularly, they don't have as big an impact as some of the things further down the list. When people had a choice here of, well, I could go out to a restaurant where there was smoking or non-smoking, they didn't always make the healthy choice of going to the non-smoking restaurant. As we change those, you see down there the changing the context. How many times do you walk into buildings, and unfortunately even this building, it's easier to use the elevator to get down here than it is the stairs. Now on other floors, it's actually easier and faster often to use the stairs than the elevator, unless you happen to know how to navigate down the back hallway. You'll notice I've added a part to this pyramid on contributing and distributive and restorative justice. And those are basically based off of our religious moral beliefs and teachings. How do we create the social economic factors and conditions that we live under? So I believe we may be the first jurisdiction in the country that actually has in our 5-year business plan increasing life expectancy as a responsibility of local government. And we have identified our lowest life expectancy zip codes, both those that are the lowest and those that aren't improving. We have our community health improvement plan. And number one in our community health improvement plan is education. We did fail in passing a pre-K recently, but it's raised awareness. We're going to go after it again. We know that it's probably one of the most important things that we could and should be doing. There were some challenges with the current one that the voters turned down, but we will be back on that. Preventable absences. We have a number of kids in pre-K that are suspended from school. And guess what? Everyone that is and was black. So there's some real issues there that, and we're holding our school systems now accountable. We've published data on their suspension rates and are getting them to change their policies on these issues. And that shows that data. If you look at our preschoolers by race and then the out-of-school suspensions, tell me there's not something going on there. So we're trying to develop better expertise in all 10 of these areas, and at different times we have more movement in the community and we can lend our support or get that issue moving forward. This just lists a number of the kinds of campaigns that we've done from power-based activity with our community. We had a 70% voter approval back in 2014 of a 9-year extension of our health levy, additional 22 million mil that generates about 15 million a year. We have done everything from ban the box to ban the ban. I don't know if you're familiar with all those things. The healthy homes rental ordinance inspection, even though a number of groups came out against that, and a number of the slum landlords put a lot of money and effort into fighting that campaign, but we were successful with 57% voter approval. Our city council twice passed raising the living wage, raising the living wage. We even took it to our voters in Kansas City, they passed it, and then the state kept preempting us. So we took it statewide and passed it in Missouri. Economic opportunity on that living wage. Again, our community health improvement plan had living wage as one of the issues. We had most of the living wage discussions and meetings here in the health department over in the multipurpose room here. And If you were from Missouri, you may have heard that in 2018 we had 1.5 million voters vote to increase the wage. So our shared values in public health with these different community organizers goes around, everybody's got a story. We believe in transformation at that personal level, at a societal level, and at a community level. Power is a product of relationships. I'm getting back to this issue of power, because we get as much social justice as we have the power to compel. And if we think about power, the arenas of power, if you think about an easy definition, power is basically the ability to act or produce an effect. How many of you in your areas that you're working feel like you have the power to increase life expectancy in your community? We don't yet. We're building towards that. And power can directly impact decision makers. It can develop stronger relationships and partnerships. One of the P's I heard earlier was partnerships. But we also have to consciously shift the narrative about how we think about what our work is about. And so Dr. King talks about power as the ability to achieve a purpose. Whether or not it is good or bad depends upon the purpose. So we need to quit being afraid of power. Now, power that is wielded in the wrong way and for the wrong purpose, yes, we have to figure out a way of countering that power with our own power. So going back to those four faces of power that I talked about in the beginning, that fourth one, the power to coerce, to maintain the status quo. In fact, I think probably the most important public health threat of our time right now is state preemption. Because almost all of our public health policies were first created at the local level and worked on and perfected, and then went up to the states in various parts of the country. And if the American Legislative Exchange Council and the Koch brothers and others can buy off the state legislatures and preempt our ability to do things, then that's why we've gone down in life expectancy the last 3 years in this country. So when I was growing up, my dad used to say, son, there's three things you don't talk about in polite conversation: sex, politics, and religion. And I grew up pretty much in white privilege, and we didn't have a lot of racial diversity, but if we had, he probably would have added race to that. So those four areas are things we have to talk about all the time as a health department. I wanted to show you, again, on this narrative concept, if our dominant U.S. view with an awful lot of people in this country is manipulated by fear of the other. And we see this playing out all the time. Part of that is bootstraps individualism. Now, I've got an ongoing bet, never had anybody collect on it, where they could show me that they can pick themselves up off the ground pulling on their bootstraps without a pulley or some other kind of a device. The phrase bootstraps, pick yourself up by your bootstraps, was originally created as a clear evidence that that's not possible, that we're not able to do things individually, we have to work collectively. But see how it's got warped in our society. Free market has all the solutions. Structural discrimination is a thing of the past. We need smaller government, not better government, smaller government. And in fact, you see this playing out where people that are being appointed in various positions are really trying to continue to hurt and harm the trust in government and aren't even filling a lot of positions to make it smaller. Science is considered to be suspect, and education is viewed as only for job training. Now, science from the tobacco industry or from the agricultural Monsantos and others that are destroying parts of our environment in the coal industry is suspect. But we can work through that. Now, alternative view would be, no, it's not about fear of the other, it's about compassion for the other, or even better, there is no other. We're all in this together. Individuals need support. Finally did stop blaming the infant that died because they were born to the wrong parents in the wrong zip code, that infant was responsible for picking the wrong parents. And obviously, when we look that far, it becomes absurd, but government can have solutions if it's not controlled by wealthy status quo folks. Structural inequities are still present. The free market needs checks and balances. Not only is science essential, but education is really for critical thinking and citizenship. So if we think about a worldview that comes out of most of our sacred texts, you'll think of the x-axis of justice. Now when I say justice, for an awful lot of people in this country, they put a word in front of it. What do they put in front of it? Criminal. Criminal justice. That's what they think about. If you remember when the 5 Amish girls were shot in Pennsylvania, the national media didn't know how to cover that story because they couldn't find anybody that was wanting revenge and retribution to talk about it. The Amish families were actually reaching out to the family of the killer to try to support them. Very different approach. Now, in our sacred texts, in all of those major religions, there are issues around retribution and punishment, but there are also texts around restorative, distributive, and contributive justice, not allowing interest rates, giving back land every 50 years, all kinds of things that are part of this. What is grace and forgiveness about in certain religions? It's on that restorative side. Now the y-axis up and down is that of power and influence. Is it nonviolent persuasion or is it force, threats, intimidation, and violence? So now you see 4 quadrants, right? So which quadrant does, quote, civilization exist in? Whether it's Pharaoh with Egypt, Caesar with Rome, British Empire, American Empire, we tend to be down here. But there are countries that have been moving up into the upper right quadrant, and I'll show you a little bit about that. I think probably back in 1970, we were about here where that star is in this country. I think we've actually backslid. Now, what is that based on? Well, think about it. If we put more people in jail than any other country in the world, if we spend more on military than the next 8 countries combined, of which all but one are our ally, if we spend more on local law enforcement than any other country in the world, I think we're right down there in that quadrant. But there was an empire in World War II, Japan. And where's Japan now? In fact, when you go back to that original list of life expectancy by countries, the countries that have been migrating up to the upper right quadrant are the ones that live the longest. They have the least inequality. They have the least amount of violence. So with that, I'll just kind of pause for any comments, questions. Hopefully I pushed everybody's button someplace or challenged you to think in a little different way. So anybody want to disagree or ask a question or point out? Yes.
So some of us in the room are from the education realm, and we are working hard to train future public health leaders who have the ability to harness power. And so the first class in our MBA program is Intro to Public Health, and I
cover the core functions of public health as a start. I'm going to put it out there, I'm not a fan, but I didn't hear you mention that today as a core function. Is it time we rethink those core functions, or should we adapt them to some of the challenges you talked about today?
So I remember when the 1988 Future Public Health came out from the Institute of Medicine, and it talked about those three core functions: assessment, policy development, and assurance. I think I was talking about, in some ways, those three all the way through here. Are we assessing and really looking at what the true causes are? Are we moving beyond what's artificially on that death certificate to what our research actually tells us are the problems? Once we sound that alarm or that lighthouse function, are we then pulling people around the table to be confronted with that, figure out what's our political will, how are we going to change our policies, and when those in power don't want that change, are we willing to take the risk to go around them to the people and over their head? And then, once we know what needs to be done, from an assurance standpoint, are we encouraging others to do the right thing, requiring them when we change a law or ordinance so that they have to do it, or doing it ourselves because it's easier or cheaper for us to do it? So, no, I think those three core functions are still there. Whether you package them and subdivided them into 10 essential services or foundational capabilities. Now remember, foundational capabilities do not cover all the essential services fully. And the FAB standards, and we'll talk a little bit about that on the panel later, there are parts that are required, I think, for fully functioning health departments beyond the foundational capabilities that are in the FAB standards that aren't in foundational capabilities, like strategic planning. How can a health department be a great health department if it doesn't do strategic planning? So I'm not sure if I'm answering your question or not.
Yeah, I guess my problem with it is since the so much of what you talked about was our need to harness our power, and in the core functions, that lighthouse step, that critical moment where you say, Kansas City, we need safer housing because it affects health, and you rally your partners and you come up with policies that will improve safe housing. That whole step where you define and you announce the problem and you rally support and build partnership, it's sort of diluted within those core functions, and I don't think it should be diluted. I think it should be really showcased as a core function of what we do, is we define a problem and we state it, and we that's the point at which we engage our partners and where we harness our power.
So it's both the data and it's also the anecdotes and the stories, because what people really remember are the stories, not the bar charts and graphs, but you have to do some of both. When I was first hearing from our staff that we had been in a home because of lead exposure, and when they went up to the toddler's bedroom, there was a hole in the floor that I could have fallen through. And this was a rental property, and they were paying pretty good rent for this, and the landlord was tolerating that situation, not fixing it. So those stories, then we started gathering our data on the 24,000, our best estimate of the rental units that were substandard from a health standpoint. But I knew that this wasn't going to be an easy sell, that there were lots of slum landlords and even those that weren't, that didn't want to be regulated or all that. So they were likely to put a lot of pressure on the city council to not do what needed to be done. So we didn't just go into the council with the data. we went into the council with that. Let me back up here, if I can get to that slide real quickly. So we went in with that number 2 step. We had the community organizers there when it was introduced. They were part of the discussion in the hearings over the ordinance. So when the council got kind of caught in a bind and couldn't really come together to pass the ordinance, even if it was watered down a little bit, the community organizing groups then said, well, we'll do an initiative petition. And one thing we've learned over time is if outside groups do an initiative petition on their own without a real understanding of how things might be done or work, they can pass something that isn't doable or doesn't have the resources to do it or actually can be counterproductive. So we actually worked with those community organizers to make sure that the ordinance that they submitted on the petition was something that we thought could and would work. Originally, they wanted to inspect every property every year. And obviously, that's not a good risk model. It would have been extremely expensive and wasn't useful, so we adapted with that. I've often felt many schools of public health that are teaching public health, how many of them actually have a course on group facilitation? I don't think too many of them have a course on power and building power. I actually find that most schools of public health don't even teach basically the 3 public health parables. Some of them don't even teach the river parable. And I just can't envision working in public health without having that metaphor model, but it's not always taught. I think you can work any of these things into any of these frameworks. If you want to, we could work together and try to create a paper on a new model if you want, but I tend to like to work within the models that are already out there, do crosstabs and try to figure out a way to emphasize. The 10 essential services didn't have organizational brand strategy in them. And that really wasn't it was hinted at in public health version 1.0 when FAB put out the first accreditation component, but it wasn't really very strong. In 1.5, we strengthened it again, and I anticipate in 2.0 we will make it even stronger because it really is essential for survival of public health in this country if we're going to really thrive. Other comments, questions?
Dr. Archer, I have a quick question about the slides you showed about education. And Kansas City Public Schools is a unique system, but not so unique in the sense that the data you showed is really focused on the school district, but not on the school system. Because then we have over 20 charters and an additional 20 private schools in the area that aren't reflected in that data that you shared. And I think this is the issue, and I was curious about public health's role with chartering and private schools and impact on that, and then how that impacts the region. Because there's other areas that are working or have charters and coming in, let's say invading, I didn't mean to say that at all, but coming into their district and trying to figure out how do we manage those data and then incorporate those data into how we work with youth.
So sometimes confession is good for the soul. So the first 15 years when I came back to Kansas City, I think one of our biggest failures as a health department was our lack of being able to figure out how to work more effectively with our school districts. We've got 14 public school districts, we've got parochial school districts, and this data was actually included charter schools. And the pre-K population is not just obviously the public schools, it's also sometimes a Head Start or other activities. So if we get to one of the fundamental root problems of this country with education is funding education on local property tax continues disparity or inequities and injustices. Other countries that have much better educational systems, that their kids are way ahead of our kids. We're down in the teens and 20s in some measures from math and science and reading and so forth, so compared to other countries. And they don't fund it on local property tax. If our redlining and blockbusting and our various injustices of the past that are still carrying forward now to some degree, because when you live in these communities, you pay higher insurances for your automobile, there's all kinds of extra costs to living in these communities. And the property values are lower, so the tax base isn't there for the school system. The Kansas City, Missouri school system has tried to increase its property tax a few different times, and it's not been successful yet. Hopefully we can get that turned around. When I was a health officer in Garrett County, Maryland, the entire school district was the county and our health department was the county. So we had 100% match. We had a few private schools, but there weren't too many. I was actually the medical director for the school systems, and we provided the school nurses, and we had the nutritionists for the school lunches, and so we had a very different integrated model of doing public health within the schools there, but we just haven't been able to crack that here. We have school districts in the Kansas City metro area that have 3 different local health departments that have responsibility for parts of that school district. It's a organizational challenge that I am sounding like, and I guess I am giving it as an excuse, but it's something we are really struggling with. And we've got some folks from some of the other jurisdictions doing the same thing.